Hi. Hello, everyone, and thanks for joining How McLeod Health Transformed OR Workflows with the IMO Core Periop. My name is Jordan Leipfitz. I'm part of the marketing team here at IMO Health. Also, thank you for, I know we delayed this a little bit. We just had some technical issues. Before we get started, a few housekeeping items. First off, we're fully recording this webinar. It will be sent to you later in the week via email. If you have any questions, please take advantage of our lovely speakers today and put your question into the question section on your Zoom webinar console. Today we have Leanne Bradley. She is the Ambulatory Application Manager at McLeod Health, and Nikki Horn, her counterpart, is the Epic Application Analyst also at McLeod. Along with my fellow colleague, Linda Casey, she is our Product Manager at IMO Health. With all of this being said, I'm going to pass it on over to Linda.
Thank you, Jory. And again, welcome to everyone. We are so thrilled you're here. Today, we're going to talk about the importance and impact of getting your surgical dictionary accurate, standardized, and keeping it up to date. And today, you're going to hear how McLeod Health approached this challenge during significant changes that they were going through and what they learned along the way. But before we dive into the challenges and solutions, let me take a moment to introduce who IMO Health is and why our expertise in clinical terminology matters for perioperative success. IMO Health is a healthcare technology company specializing in clinical terminology and data quality solutions. We were founded more than 30 years ago with the mission to bridge the gap between clinical language and standardized medical coding. We enable healthcare providers to document care in a clinically meaningful and technically precise way. At its core, IMO Health develops and maintains a comprehensive clinical terminology platform that integrates directly into electronic health records. And this platform allows clinicians to use familiar, intuitive language while ensuring that the data captured is structured, standardized, and interoperable. We often say that we let clinicians speak clinician. Our terminology solutions are deeply embedded in the US healthcare system. They're used by hundreds of thousands of clinicians across major health systems. And you'll hear by improving the cleanliness and consistency of clinical data, how IMO Health empowers providers to really make better informed decisions, coordinate care more effectively, and ultimately improve patient outcomes. So the next slide, please. What is the challenge we're going to talk about today? So most of you know that operating rooms provide more than 70% of a hospital's revenue. But at the same time, they are also the largest cost center within most healthcare organizations. So every minute in the OR counts. And it's incredibly important for hospitals to optimize their workflows and the time spent in the OR because it has a huge impact on their profitability. And the key is really having an accurate, standard, and up-to-date surgical dictionary. And we know that manually updating the hundreds or potentially thousands of surgical procedures and associated codes is neither effective nor efficient. And yet, without having a standard and up-to-date dictionary, ORs can't operate efficiently, and this has a huge impact on the bottom line. So it's really essential to have that accurate dictionary to schedule your procedures accurately and to optimize your OR time and to prepare the OR and minimize waste, making sure you have the most accurate room setup and equipment. And also, it's essential for prior authorization all through billing and effectively getting the optimal reimbursement. And some stats show there are over 48 million surgical inpatient procedures performed in the US every year. So we know that the OR time is expensive. We know it requires significant coordination. We also know that surgical documentation is really critical to that reimbursement and patient care. So next slide, please. Why do we focus on the surgical dictionary? Well, because these perceived small inconsistencies in the dictionary upstream really turn into big downstream issues, such as inconsistent data across the searching and ordering, having close enough scheduling but not accurate, having missing or wrong CPTs and even imprecise data durations, which is a huge impact on the OR, as well as having challenges maintaining the preference cards, So we routinely see dictionaries that have 50% of unused or even deactivated terms still in them. 3/4 often have missing CPT codes rather. Almost half of the dictionaries that we see have no CPT codes at all. And about 1/4 often include wrong CPTs before our surgical dictionary cleanup. So the point here is when organizations fix this, we have seen results such as fewer inpatient-only denials, dramatically improved case durations and block utilization of their surgical theaters, and even a 3.5-fold or more improvements in patient estimate accuracy. So with the last slide here, really, we're just talking about the through line for today is really when you have consistent terms and codes, those are really the thread that ties everything together from the surgical order to the scheduling to the pre-op, intra-op, all through the charge capture and reporting. And when you get that right, everything else just gets easier and more accurate. So with that, let's bring this story into focus and let's turn to McLeod Health. We'll start with a quick introduction of who they are and then explore the challenges their team faced on their journey to optimizing their perioperative workflows. And with that, I'll turn it over to Leanne and Nikki.
Thank you. I'm going to let Nikki talk about McLeod Health as a whole.
So here at McLeod, we currently have 8 hospitals we're building a new one, over 100 physician locations, over 1,000 licensed beds with over 15,000 team members. We are continuing to grow. We have a new surgery center up and coming, along with a new hospital that has ORs. You want to go to the next slide, please? Yeah, so when we first implemented IMO, prior to IT, I was an OR nurse, so I was on paper documentation. So up until September of 2019, we were still documenting on paper in our operating spaces. And then we moved to Cerner, and then it wasn't very long after that, in December 2022, when we moved from Cerner to Epic. What was unique about our situation was we adapted IMO along with Epic implementation. So we didn't do those separate, we did them simultaneously. Currently, our surgical dictionary has about 1,600 procedures in it. When we switched to IMO, Leanne and I did a crosswalk of our previous surgical dictionary, and we were able to about cut it in half by cutting out some of the extra verbiage and things that providers like to use, realizing that essentially at the end of the day, it was the same procedure. So that was helpful. It's easier to maintain a smaller dictionary.
We were able to cut out a bunch of physician-specific procedures that helped eliminate a lot of our dictionary.
So we have about 93 operating rooms. This isn't including like our cardiac invasive. This is just our OR, endo, and OB, and our CVOR. There's about 93 operating rooms total across our sites, with about 6 more coming. I think the next slide kind of shows our volume of what we do. I did it by the past 6 months. So roughly about 5,300 procedures a month. So you look at, 60,000 plus procedures in a year if we stay on this track. And that's kind of who we are as McLeod.
Thank you for that intro. That's fascinating. And I think what's particularly fascinating when you mentioned that you pretty much have the number of procedures after implementing IMO. And you talked a little bit, you just mentioned there you had physician-specific procedures. Could you talk about what those were and why it was important to get rid of those and standardize?
Yes, so a lot of what we had were if a physician wanted it a specific way, he had specific positioning. There were procedures created versus the preference cards being created. And when we were able to eliminate those physician-specific, lap chole, Dr. Sonfield versus lap chole, Dr. Goss, They're still a lap chole. We utilize the preference cards to more succinctly pull in the physician preferences that were needed versus trying to do different procedures.
It's fantastic. Did you have any pushback from the surgeons when they did not have the procedure that had their name on it?
Initially, when we were, because this was part of our implementation of Epic as well, we did this simultaneously. We were holding what we call SPA meetings, which is procedures orders management meetings, and we had physicians and surgeon champions on that call. We brought that to their attention, and as a collective group, we allowed them to make the decision that those were no longer needed, that we were going to utilize the preference cards. Even though that was kind of our plan all along, we kind of let them feel like they were the ones making that decision. And as a group, the surgeon champions all agreed that if it was something that was surgeon specific, we would move that to a preference card versus a procedure.
Oh, that's fantastic. It's a great best practice too to share with the group on the call. Before you implemented IMO Core Periop, and I understand you did it at the same time that you were migrating to Epic, did you find that you were lacking CPT codes? Were those causing any denials?
Prior to going to IMO and Epic, we used something called Order Facilitator. It was more like a fax option. The order was written down on paper. There were coders in the office that found the specific code before it ever came over. So I won't say that we necessarily had a lack of CPT codes um, because they were doing it a different way. Since we have gone to IMO, multiple CPT codes can be attached to a procedure. Um, and so that's a key point. I'm sure we'll get into that a little bit later when you're ordering a procedure and which procedure you pick and which CPT codes that you pick. Our prior auth has changed a little since we moved over to IMO, just in case it's not a CPT code chosen, or if the incorrect one is chosen.
Could you talk a little bit about that? What has changed and what are you doing now that has made a difference now that you have that additional functionality and those additional codes?
Yeah, so if there's no code chosen, Leanne and I kind of went in and built something in the background that all the codes will go over for authorization. While that can be a little tedious for our authorization staff, it's necessary to have codes. Sometimes there's more codes than they would like. So we try to just, when we're building new procedures or choosing what we're going to put in our dictionary, we try to choose things that have fewer codes attached to them. So it's not as robust if the provider or whoever's entering the order doesn't pick a code. It's more of a generalized group of codes that go with that procedure to kind of try and help them to be able to pick the correct one so they're not often for 10 to 15 codes when it could be 3 or 4.
Mm.
And one other change, prior to it, when they were on Cerner, they did not necessarily have CPT codes attached to specific procedures. They had the coders in the office, and the prior auth team got the code from the coder for that procedure, but the two weren't married together. With Epic and the IMO implementation, we were able to marry the CPT codes to the procedures based off of the IMO dictionary. And then if there wasn't a code chosen, we put that build in place so it would automatically go over. So I think that's one of the biggest changes that our prior auth team has seen is they're automatically getting codes regardless of whether one is selected from the office. They get all of the codes.
And maybe you can answer this and maybe not, but have you heard if that has saved them time because that's less work that they have to do to find those codes in order to submit them or rework them even?
So it's kind of a mix between the two. If it has too many codes, right, that are attached to it in IMO, that can cause them some rework because they have to figure out, okay, which codes do we pull. But we're working went through a huge process of educating the office staff when they're entering those orders to ensure that they're choosing their primary code in that case request, that they don't just say, oh, well, it says no codes. We need to go in and make sure that it has a code chosen with it. So we've done a lot of education on the ambulatory side with the schedulers and the providers that are entering the orders to make sure that they are selecting that code to decrease the amount of work that the prior auth team has to do.
That's fair. And I know that we have customers who also say, because we do provide, depending again on the specificity of the term, that there may be more or fewer CPT and HCPCS codes. And
Correct.
some of our clients have the need to have those additional codes when they're doing prior authorizations during surgeries as well, depending on the surgery. So it's sometimes helpful to have those additional codes right there to be
Right.
able to in the moment. So that's great. You mentioned training and some of the ways that you've worked with the different teams to really make the implementation smooth. Could you talk a little bit more about the training, even from the beginning of the implementation through the end? Some of the things, some of the challenges that you might have had, and also how did you effectively get that training done in your organization?
So I will say training for us was a huge thing that we wish we could have done better or had done better in the beginning during implementation. Surgery schedulers in the office are kind of hybrid employees because they do a lot of work in the op time world, but they also do mainly ambulatory work. So they're kind of the folks that nobody knows who owns them sometimes in organizations, and their training can be less than because maybe we didn't know we needed to hit them. We thought ambulatory was hitting them. Ambulatory thought op time was hitting them. So we had, I will say, in the first few weeks, there was a lot of work that had to be done with all of the surgery schedulers in the office to help them understand their workflows. We figured out very quickly that that was a deficit in training for implementation for us. Um, Nikki and I worked very closely with some of the Epic trainers to make sure we came up with like a guide, basically, that kind of walked them through step by step how they were going to be ordering it, what each thing meant, how to enter the procedures appropriately, and making sure that the procedures descriptions were correct and all of that. So there was a lot of post go live work with education that went on, and it's pretty consistent even to this day. We're still, it's a constant training and constant making sure that you got to choose that CPT code. You got to choose the right procedure. Do you search by procedure or do you search by CPT code to best find the procedure that you're wanting to do? So that is something that we constantly tackle. Nikki and I spend a lot of time in provider offices with surgery schedulers as analysts. We kind of took that role to own that group and make sure that they understood what they needed to do, when they needed to do it, and how they needed to do it, and why they were doing it that way, to give them the back end as well. So that was a huge focus for us.
Did you give advanced warning when, I guess, you had purchased IMO Core Periop and that this was coming? Did folks know, or was it mostly after it was implemented that people got the word and then you started that training?
I feel like we gave them advance warning. However, the warning was kind of, it came with Epic. So I don't know that they know that it was just all this change was from IMO, or do they think that it was Epic related? Probably a little bit of both, because we did them at the same time. So we didn't specifically say, it was kind of like, this is how it's going to be when we go to Epic. And we chose that opportunity to pull in IMO at the same time.
Yeah, and that's a lot. That's a lot of change, and kudos to you for doing that. Do you have any recommendations for the group to when you say you had different training for those different teams and it's ongoing, is there anything you can share that are you creating documentation and any guidelines you might share, tips and tricks on how you are approaching that from this point moving on?
So one thing we had when we did training, all of our training was Epic led. Um, and for facilities that are doing Epic led training, if you're doing this as part of an implementation or whatever, make sure that your surgery scheduler group gets some special attention and some special love. Make sure that you've got tip sheets on case entry and making sure you've got kind of an implementation guide actually for them, kind of step by step from beginning to end for your different scenarios, um, of whether they're putting in the order, somebody else is putting in the order, or they're going back and adding orders after the fact or updating. Just making sure that you've got all your scenarios covered and educated on all of that.
Great advice. And I know one of the things that we've heard from other customers as well, I'd love your take on this, is as you are reviewing your dictionary with certainly the clinical folks, the surgeons, and making sure that the terms were in fact and the codes were matching what they were expecting, uh, do you have any advice in terms of how you handled that? Did you have specific specialties come in at specific times, because we know the timing, everyone is very pressed for time to give any time to anything outside of their day job, so to speak. Talk a little bit about how you handled that to get their buy-in and confirm what the codes were, whether the rev cycle team or with the surgical team.
Um, I think for the most part, we it wasn't really so much buy-in from the providers. I think one of the biggest things that we've seen when you have providers in the office that are very well versed in their codes, everything works very smoothly. Even our off cert people will say it's perfectly fine for them. It's we tend to have a bigger issue with general surgery, because I think lesions, hernias, there's just a lot of codes that come with that, because you start talking about size in centimeters. How big is the hernia? Is it recurrent? Is it um, reducible? All the things. And then the lesions, it can be from small to large, and there's a different code as the size gets bigger. So that has been a big challenge with us recently. With the general guys, we've had to start including some of those numbers size wise in the IMO name, in the procedure name for the dictionary, just to help offset some of the difficulties that they were having. Um, so I would say, for the buy-in, I think it's been okay, because we do have the dictionary for IMO to go back um, to say, this is what is mapped to it, and this is why. There's lots of options we have, so it kind of comes down to what's best for your providers and your facility, um, to get them what they need to choose when they're doing their case request.
It's helpful. And
We also, and Linda, sorry to interrupt, but we also had our SPOM work group, which was comprised of lots of surgeons, and we had our operational work group, which consisted of all of the OR directors. Um, so if we had questions, concerns, or we were unsure of procedures and we wanted to validate with them, we would always use them as our kind of final sign off and validation for those conversations.
oh, thank you, Fran. That makes a lot of sense.
And
And
we
to
still
the
do that. We still
Yeah.
do that if we have ones that there's controversy over. We get the operational folks involved.
and to that point, thank you for that. That's a great next segue there. So speaking of governance, so you have this clean, up-to-date, standardized dictionary now. Could you talk about some of the ideas for governance that you plan to use or you have in place for when new procedure requests come or code changes come? Who approves that? How quickly do you move? Talk a little bit about how that's working in your organization or how it plans to work in your organization.
Currently, we have a ticket process, if you will, and they can put in a request for a new code to be added, if it's something that they currently don't have. And then it is on one of the op time analysts. There's two of us at our facility. Will one of us will go into IMO and try to, if it is clear cut, we can add it on our own. It's not a big deal. If it's something that gets a little controversial where you need a little more feedback, we can send options over to the requester who can then ask the provider to get that information back to us. I mean, it's typically a very quick turnaround when they ask for new terms, I would say within a day or two at the most, to get those in. When it comes down to the charge level of the procedure, um, if it's very similar to another one, we can go with the same charge level. But if it's something that we're unsure about or it's brand new, we get operational folks to let us know what charge level um, is associated to it. And that was another thing we kind of learned with our dictionary in IMO. You'll see that laparoscopic and robotic assisted can be the same term. Um, but our facility didn't care for that much because it was difficult for preference cards and case picking. They open totally different instruments for laps than they do for robot cases. And we charge differently. A robotic case here is a level higher than a laparoscopic case due to the just how much more it costs to run a robot, to maintain a robot. Um, so for that reason, we have those built out separately. So it's little things like that I think that we've learned along the way um, to help make it better for them.
That's
Anyway.
fantastic. And that ties in really to that OR efficiency and the improvements, that case duration accuracy, the OR utilization, and making sure that you don't have any waste that's happening. You mentioned the differences in terms of the equipment needed for the robotic procedures. Could you talk a little bit about how you have seen a difference after implementing IMO Core Periop in terms of having that efficiency because of that crisper term and because of the way that you now have the ability to truly define at a very precise level what is being scheduled?
Yeah, so we have done a lot of work with our OR metrics, with all of our KPIs, with case length accuracy, the room utilization, block utilization. We've really worked a whole lot with that. We've made great strides by cleaning up our dictionary, by getting that true accurate case scheduled the first time, so that we don't have a lot of that. Our KPI metrics have significantly increased. I probably should have pulled those, but I want to say our case length accuracy for our main campus here in Florence, the larger campus, the mothership as they call her, was in excess of 90%.
Is important when you talk about OR time and duration. I was looking at some of our numbers before this call, and based on the complexity of the case, anywhere from $110 to $218 a minute is a lot of money. And so you want to try to fit as much as you can into a surgical schedule during your peak hours for revenue. So it's important to have those time durations accurate.
That is staggering. Those are really high numbers. And I loved how you mentioned you had 7 levels. In a previous call that we had,
Yeah.
7 levels of OR. And the fact that we talked about earlier, the importance of knowing that the OR is your, revenue generator, but it's also your highest cost, and every minute counts. Every minute counts, and you have very, very high data there to confirm that. Um, if you had to justify the investment, I know you've been in Period for a few months now, but if you had to justify the investment today, what is your most persuasive ROI point that your executives, I know there are several executives, so pick and choose which ones you want to talk about, but which ones do you think they care about the most? Is it the write-off avoidance? Is it rework reduction? What would you say?
I would definitely have to say our denial rates and the amount of write-offs that we've had to do. Our OR waste has decreased significantly for um, opening unnecessary items, being able to decrease the number of trays that we bring in, because we've got a clearly defined process and procedure that we're doing. That OR the sterilization turnaround times, all of that has truly been just the money saved in becoming more efficient.
Yeah, I
So
was going to
worth the
say just
investment.
overall efficiency of, one of the biggest, if the largest moneymaker of the organization, your OR. So,
No, that's great. And speaking of the efficiencies, can you talk a little bit about how did you handle the annual CPT updates? The HCPCS are updated quarterly, but how did you handle any of those code updates before IMO? And talk a little bit about how you plan to do this after IMO.
I'm not sure how they handled it before IMO. I don't know if Leanne knows or not, but from me, I was here when we were on Cerner as well as an analyst, and the CPT codes weren't attached at all to the procedures, so I didn't have any part in how those got updated. Very little knowledge until we actually went to IMO with Epic of how the CPT codes are attached to the procedures and why it's so important. Um, Now IMO provides an update that we take yearly, and we can just go into IMO and export it and make any little tweaks or anything that we need and put it in Epic format and just upload it right on in. So it's a very simple process for any updates and changes that come.
And just
Yep,
to emphasize, you can upload your files quarterly to get the HCPCS updates if you choose. You don't have to wait till the end of the year just for the CPT. So we update the HCPCS quarterly. So that's just open information if you'd like to upload your file and get those updates as well. But that's great to hear because that is one of the main value drivers I know we hear from customers is really the ability to take that burden off of having to manually update those codes. You have hundreds updated each year, which could affect thousands of your terms, and having that done for you and knowing that it's accurate every year is just a huge burden and a huge uh, lift off of an organization.
absolutely. And I think before, most of those updates went to the coders, whether it was on the front end at the office or it was on the back end for coding the operative notes. I'm sure they were the ones that got the updates, from what I understand. Um, that they would know, hey, this is no longer a valid CPT code. We need to update this. This is your new code you're going to be using. But as far as us actually updating them in the system, because we didn't have them tied to that before.
There. I know the group would love to probably hear some lessons that you've learned, any advice you could give, and you've given them throughout this fireside chat already. But if you were to start over, what is one step that you would do earlier? Is it metadata decisions? Is it pre-work on preference cards or any kind of leadership alignment? What would you say to that?
For me, I would say work on preference cards, definitely, um, and education of the staff in the office that are actually going to be entering the case request orders if it's not the providers, and the importance of that. And we're currently discussing putting a hard stop in Epic to make them pick a code, because you have some that are really good at it and some that just aren't. Um, and then outside of that, I would just, support. I mean, I think Leanne and I do a good job, but they need to understand and know that it's a big process change for them. So they need to understand the importance of everything and why CPT codes are important. Um, so those would probably be my biggest takeaways: pref cards, CPT code importance, and education.
Would you agree with that, Leah?
Absolutely, that and some specificity of the, like, instead of versus, we'll use upper extremity or lower extremity versus elbow, wrist, forearm, shoulder, that sort of thing. Maybe having, I kind of wish we had done a little bit more specificity for body regions. But other than that, I think everything Nikki mentioned, that's the biggest key, is had we identified lost that lost group for training in the beginning, that was huge for us.
Good advice. And And as a follow-up, what pitfalls might you warn your peers about? For example, any CPT timing updates or block schedules or underestimating of anything down cycle that has a rev cycle impact? Any kind of pitfalls that you want to warn folks about?
One pitfall I will warn about is you need provider engagement early on, um, so that they're not coming in at the back when it's all said and done and you're finished, and they're like, oh, well, we don't like that naming. Well, sorry, you should have spoken up in the beginning when we were having all of our SPOM work group meetings. And um, one of the other things Nikki mentioned earlier is preference card work, especially if you're going to be deleting procedures or you're going to be adding new ones and kind of getting more specific on body regions and things like that. Just ensuring that your preference card builders are involved in that process and they are aware of that process so that they can make their updates and make sure that their cards are what they need them to be.
Mm, good advice. Nikki, would
Because
you
that's
agree?
also going to drive your case length accuracy as well.
Absolutely. Anything you want to add to that, Nikki?
No, I concur. I agree with all of that. I think along the way, we've kind of been side by side in this whole process. So we've,
Yeah.
That's great. And before we look at the Q&As, last question I have for anybody who might be on this webinar now who may be evaluating IMO Core Periop, what would be your one-line value story to help them drive internal buy-in?
I think for me, the the ease of the updates, the way you guys provide your updates, and you can just basically export it out and import it right into Epic, and it does all the work for you. That to me was huge, as well as the charging pieces, helping with charges, getting the correct charge out to begin with.
I agree with that, and I would add that the the validity of having the dictionary. There's a specific surgeon I can think of that he likes to pull out his AMA coding book and tell me this is what this says in the AMA code book, but we opted to go with IMO, and that's what we use facility wide. So it's nice to be able to have that data bank, if you will, to go back to and find the procedure, find the CPT code, see the options um, as your source of truth. That's been helpful when you have some folks that kind of like to argue about it a little bit, or if you will.
Mm, appreciate that. Well, thank you. I'm gonna. Any other comments you want to make before I jump into taking a look at the Q&As?
I think that's it.
All right. Well, thank you.
Question.
Phenomenal. Appreciate both of you sharing your experience and your insight. And it's been very valuable, I'm sure, for a lot of folks on the call. Certainly, I love hearing about it. I'm going to start at the bottom of the list here and see what we have. Sorry, we have thought about making CPT hard stop, but we have a lot of emergent cases, is the comment. I'm not sure if that's a question or just more of a comment. We thought about making CPT hard stop, but we have a lot of emergent cases.
I think she was saying, she asked if are you a level 1 trauma center?
Oh,
No.
there we go. Sorry, I shouldn't go upside from the bottom up. Okay, so let me start at the top then. You're right. I was trying to work my way up. So let's address that. Are you a level 1 trauma center? And then thank you for that. And we thought about making CPT hard stop, but we have a lot of emergent cases. Thank you. That makes a lot more sense.
We are a level 2 trauma center, um, but we do still get a lot of emergencies in which we use the trauma button.
Right.
Um,
Which, if you're not familiar with that piece, it's just kind of like with STEMIs, it just creates a generic procedure, and it places the patient on the schedule immediately, all in kind of a one click type deal. And then once they get the patient in the room, then they update that procedure to the correct procedure. It just schedules them for a trauma procedure, and then once you get in, you can actually go in, update your procedure to include what you actually did during the case, and you could use your CPT codes, choose your CPT codes at that time. So if even if you make it a hard stop,
it wouldn't affect that trauma process if you utilize that. it kind of bypasses the order. It just puts a placeholder, and once your patient is stable and everything settles down, you can go in and fill in. It has a generic provider attached, and it just says trauma or emergency trauma on it, and you obviously update the procedure to what you actually did. So the hard stop wouldn't affect that workflow or the way that we do it.
Perfect. All right, I'm looking here. So is the trauma button on an IMO? I'm sorry, is the trauma button an IMO build or Epic? That's definitely an Epic build. That's not
Yes,
coming from IMO. Another
it is
question.
definitely an Epic workflow.
Yeah. If you change a CPT code for future cases, does it affect cases that already have been completed?
No, it's going forward.
Okay, for the CPT4s you mapped, did you set just a couple as default or just attach them all to get the auth insert?
We attach them all.
Yeah, we attached them all, and we put some build in that regardless, if there's not a code selected, then they get all of the CPT codes attached to that procedure.
They can still see what was selected if something was selected, but yeah, we opted to send them all to make sure they just had the coverage that they needed when authing the patient.
There's a question here. How much did you save in denials?
We were not able to get a definitive number before the call. Our previous director or AVP that was over that and with the project recently left. There's been a changing in the guard, and so we weren't able to get that information prior to the call. But I will say that the denials did significantly decrease.
Fantastic. Here's a
So I
question
don't.
for me.
Sorry.
Oh, that's fine. Will IMO be working on CPT codes availability for ambulatory care? We have them. We actually have a flag for ASCs that can be either covered or excluded. So that's already part of our solution. So that is in there. Next question. What do you utilize to check a CPT code when a provider requests a new CPT code be added to the system?
That is when we go out to IMO Periop and use a Periop mapper, and you can search by procedure name or by CPT code. Once you learn how to use that tool, it's a very simple tool. It's very easy to find the CPT codes that they're looking for and what's mapped to it. So we
And
use
just
the mapper that's provided by IMO for that.
And just for folks who may not be familiar with our solution, we currently have two tools. One is called Mapper, one is called Menu. The Mapper is what currently is primarily used for that initial implementation currently the end of the year. We encourage it to be used year round, so you can always use it to separate by service line and take a look and just for your own internal management of your data. But we also have a tool called Menu, and think of that as a repository that anybody in your organization can look up a code or a term and see what the available options are. And what that typically is used for is kind of the sanity check. If you get a code, and how often does this happen, Leanne and Nikki, but you might get a code or your schedulers get a code or a term that is not making sense. Either the code is outdated, it's not matching, something's wrong about it. Do you go into, or maybe talk about how you would go, or your team would go into the menu tool and actually search for what potentially could be the correct term? But we do
Yes,
that.
my apologies. I said that backwards. We use the menu tool, and that is where we search for a requested CPT code to see what our options are for adding it.
Perfect. Let's see here. Have you considered centralizing your surgical scheduling team at each facility? I manage a 32 surgical scheduler team for 2 facilities who also schedule at other sister sites. It's been incredibly beneficial for training and accuracy.
We would love that. I just don't know that our organization has reached that level yet.
And then we do have a centralized scheduling area, but they don't do surgical cases.
Right.
They do like your IR, cath, things like that. They don't do OR. Not saying they never will or that we won't get there, but currently it's just a more specialized group of folks.
Yeah, we have not reached that level.
Next question is, I work for a level 1 trauma center. How difficult is the workflow for those more specific cases that may not fall into these procedure bundles?
So I'm not sure I fully understand that question.
I don't.
Um,
I think I understand. Maybe I'll try to answer what I think they're asking. Um, it's really not a procedure bundle. You can get as specific as you would like.
Yeah.
I mean, if I wanted to, I could go in and put one CPT code to one procedure and make everything a one-to-one match. I mean, IMO has that capability, but that's a lot of maintenance on the analyst side, which is why we try not to do that. But we absolutely have that ability. I had an example the other day of a orthopedic guy that they use a specific type of case when they're doing an L lift, and he wanted a specific procedure built for that specific type of L lift, and I built that for him with the CPT code that's attached to that. I mean, they're probably the only ones that will order it, but that's what they wanted for their preference card and accuracy, and they do it very frequently. So, I mean, that's always an option. It doesn't have to be bundled per se.
you. Another question here says, how are you handling times when procedures change in the OR and you need reauthorization or ensure that changes in the procedure didn't result in an inpatient-only CPT code?
So there is a utilization review specialist that works through PACUs that reviews those cases when they come out, if anything has changed. We also have a work queue that catches all of those procedures where the code changed during the procedure, what was off versus what was done are different. And they have someone that works those to get those prior auths updated and reviewed within 24 hours. So our utilization review team works very diligently to get that done.
Thank you. How do you address intraoperative changes in CPT codes that were pre-auth? I think it's a similar question there.
Yeah, so if it changes, it would go to that work queue or it would go to that utilization review specialist in the PACU area, and they would work with that insurance company to get the authorization updated for anything that may have changed. Because most insurance companies, again, understand that you going in for a procedure, you may or may not, I mean, they may find something else when they get in there. So it's kind of an unwritten rule that I think you have 48 hours, 24 or 48 hours to get that updated authorization based off of what actually did happen in surgery.
Mm. Here's a question. Is it possible for IMO to be married with Cerner? Our health system currently uses Cerner. We would love to talk to you about by you saying you're married, we want to be married with Cerner, assuming you want to be partnered with Cerner. I know Cerner has its own dictionary that is baked into the solution, but we are constantly looking and talking to Oracle Cerner customers about the benefits of IMO Core Periop from what you currently have. So feel free to reach out. I know there's going to be information about how to reach us at the end of this, but let's have a follow-up conversation about that. Let's see here. Who is responsible for entering that? Okay, sorry, I think this is the one we just talked about. How do you address interoperative changes, and who's responsible for entering that code change so it goes to a work queue? I believe you answered that, Leanne, so. Okay.
Yeah, the intraoperative nurse would update the procedure that was actually being done during the case, and whatever codes were associated with that procedure would then show for utilization review.
The providers also have the ability to update that code in their post-operative space when they're doing their op note.
Thank you. Are coders involved in that process at all for the CPT changing in the UR work queue?
Not in the beginning anymore. Before we had IMO and Epic, we had coders in the office that were closely involved in the process. Now it gets to them after the procedure is done.
And they code off of the operative note.
Okay, answered that one. And there's a code, IMO helps with ICD-10-DX codes. How are the CPT codes being discussed using IMO? Is that a question for IMO? I'm not sure.
I think so, Linda. But we
IMO
can.
Health with the DX? How are the CPT codes being discussed? I guess I'm not quite clear what that question is. You're talking about within Periop or within some of our other solutions? Because our Periop solution does not have ICD-10 DX codes inside. We are only with CPT and HCPCS. So we do have solutions that do map to ICD-10 DX. So maybe I can certainly take it offline and get more details to what that question's about.
We can follow up with him afterwards.
Yep. All right. And I think we answered the two that remain that I'm seeing anyway. So if there are no more questions, I want to again say a very, very big thank you to Leanne and Nikki for joining us today and for sharing your experience with IMO Core Periop. It has been just a pleasure to talk to you and hearing what you have gone through and just the exciting changes that have been made in your organization. So thank you for your time and thank you for everyone for joining. And I'll turn it back to Jory.
Thank you so much. Yeah, thank you, Leanne and Nikki, and also Linda. Super appreciate you for doing this. I just wanted to call out that we have a few upcoming webinars. On Monday, this coming Monday, we have Advancing Rare Disease Diagnostics, How Ontological Tools Transform Care and Research. That is quite the mouthful, but we have speakers from UNC and Johns Hopkins on that one. So it's going to be really, really interesting and really good. Next, then we have Wednesday, August 27th, getting ahead of denials and simple fixes for smarter coding. And then our most popular webinar of the year is on September 11th. It's our ICD-10 2026 code set release update, where we have our expert coders kind of go through all the new changes that happen. And so with all of that being said, we're going to go ahead and close out. Thank you again. I know there's so many other ways you can spend your lunch hour. So thank you again for joining us today. And I hope you have a great rest of your day.
Thanks, everybody.
Thanks.
Thank you.